Benign prostatic hyperplasia, or BPH, refers to non-malignant enlargement of the prostate gland caused by prostatic cell proliferation. BPH is the leading cause of lower urinary tract symptoms in biologically male adults, especially after the age of 30. On the other hand, prostate cancer is a common malignancy that usually affects biologically male patients between 64 and 75 years of age. While BPH and prostate cancer both present with urinary symptoms and are differentiated based on clinical and imaging findings, BPH does not increase the risk of prostate cancer. When a patient presents with a chief concern suggesting BPH or prostate cancer, first perform a focused history and physical examination. When it comes to BPH, affected individuals typically report difficulty urinating, a weak urine stream, and occasionally nocturia or urinary incontinence. Digital rectal examination, or DRE, often reveals a firm, symmetrically enlarged prostate. With these findings, you should suspect BPH. Here's your first clinical pearl. Keep in mind that DRE can only detect prostatic hypertrophy once the prostate volume reaches 50 milliliters or more. Whenever a patient presents with lower urinary tract symptoms, remember to perform a neurologic examination by assessing motor and sensory function of the pelvic region and lower extremities to rule out other causes. Now, once you suspect BPH, order a urinalysis to rule out other urinary tract pathology, such as infection, and consider ordering a prostate-specific antigen, or PSA, level. Here's a clinical pearl. While PSA testing has a limited ability to accurately predict urinary retention or prostate size in patients with BPH, results might be useful when determining treatment. Using shared decision-making, be sure to discuss the risks and benefits of PSA testing with your patient. Okay, in addition to lab testing, consider ordering a post-void residual, or PVR, scan. This test measures the amount of urine remaining in the bladder after voiding to look for evidence of urinary retention. Additionally, order a transrectal ultrasound, which can assess prostate size more accurately than a DRE. If your patient has no coexisting urinary tract pathology, the urinalysis will be negative for bacteria, protein, blood, white blood cells, and glucose. However, PSA levels might be elevated, and PVR might indicate mild to moderate urinary retention. Transrectal ultrasound typically reveals an enlarged prostate, which confirms BPH. Next, to determine an appropriate treatment plan, you'll need to assess your patient's symptom severity. To do this, have your patient use the International Prostate Symptom Score, or IPSS, a self-administered, validated metric that predicts the severity of urinary retention. This metric was previously called the American Urological Association Symptom Index. The IPSS questionnaire assesses the frequency of 7 specific BPH symptoms, including incomplete bladder emptying, urinary frequency, hesitancy and urgency, weakness of the urinary stream, straining with urination, and nocturia. IPSS also assesses a patient's quality of life to determine symptom severity. The score ranges from 0 to 35, with higher scores predicting a greater severity of urinary retention. Now, if the IPSS score is less than 8, diagnose mild BPH. Here, treatment primarily consists of behavioral and lifestyle modifications to alleviate symptoms. For example, your patient can reduce urinary frequency and nocturia by limiting fluid intake before bedtime or travel, and by reducing consumption of caffeine and alcohol, since both have a diuretic effect. Finally, be sure to recommend regular physical activity, pelvic floor muscle training, and weight loss if indicated. On the other hand, if the IPSS score is between 8 and 19, your patient has moderate BPH. In this case, treatment includes behavioral and lifestyle modifications combined with pharmacologic therapy for symptom reduction. First-line medications for BPH include alpha blockers like tamsulosin and phosphodiesterase 5 or PDE5 inhibitors like tadalafil. Both medications relax the bladder and prostate muscles, which improves urine flow. Now, if these medications do not improve symptoms, consider starting a 5-alpha reductase inhibitor like finasteride or an anticholinergic like sulfenacin. Alternatively, you could start combination therapy, which could consist of an alpha blocker with any of the other medications or a PDE5 inhibitor combined with a 5-alpha reductase inhibitor. Keep in mind that 5-alpha reductase inhibitors are more effective for patients with moderate to severe symptoms and an enlarged prostate. For this reason, you should only combine an alpha blocker with a 5-alpha reductase inhibitor if your patient is symptomatic and has a prostate volume greater than 30 milliliters on a transrectal ultrasound, a palpably enlarged prostate on digital rectal exam, or a PSA of 1.5 nanograms per milliliter or more. Time for a clinical pearl. PDE5 inhibitors like tadalafil are often used to treat erectile dysfunction, but since they can also effectively treat BPH, consider using them as a first-line treatment for patients with both erectile dysfunction and BPH. Here's a high-yield fact. Patients who undergo cataract surgery while taking alpha blockers like tamsulosin are at increased risk of intraoperative floppy iris syndrome, or IFIS. This complication occurs when the iris becomes flaccid and prolapses through the incision site during cataract surgery, which increases the risk of serious complications like retinal detachment. Before starting an alpha blocker, find out if your patient requires cataract surgery, and if they do, wait until after surgery to start the alpha blocker, using shared decision-making with the patient and their ophthalmologist. Finally, if the IPSS score is 20 or greater, diagnose severe BPH. Just like patients with moderate BPH, those with severe BPH should begin behavioral and lifestyle modifications combined with pharmacologic therapy. Additionally, some individuals may benefit from surgical intervention, such as prostatectomy or transurethral resection of the prostate, also known as TURP. Alright, now that we've discussed BPH, let's move on to prostate cancer. Affected individuals often experience difficulty urinating, but some also report weight loss, night sweats, or a family history of prostate cancer. Other patients are asymptomatic, but are found to have persistently elevated PSA levels. Physical exam may reveal prostate nodules or asymmetry. With these findings, you should suspect prostate cancer. Here's a high-yield fact. Patients are at an increased risk for prostate cancer if they have a BRCA1 or BRCA2 germline mutation, a first-degree relative who died of prostate cancer, a first-degree relative who was diagnosed before 60 years of age, or a family history of Lynch syndrome, a genetic condition associated with multiple malignancies, including colorectal, ovarian, and prostate cancer. Let's follow that up with the clinical pearl. PSA testing and digital rectal examination should not be used to routinely screen for prostate cancer, since routine screening has not been shown to decrease mortality, and false positive results can lead to unnecessary biopsy and treatment. Instead, for patients ages 55 to 69, use shared decision-making to weigh the risks and benefits of screening and offer screening to those who requested it. Additionally, you can use validated online screening tools to identify patients with a higher risk for prostate cancer who may benefit from further screening. Now, once you suspect prostate cancer, order a PSA level as a baseline to compare with post-treatment levels. Also, obtain a multiparametric MRI, or MP-MRI, of the prostate to detect any clinically significant prostate lesions and to help guide the biopsy. Then, obtain a transrectal ultrasound-guided prostate biopsy with pathology. Results typically show a PSA that is elevated, and MP-MRI demonstrates a prostatic lesion suspicious for cancer. Pathology will confirm a clinically significant malignancy such as adenocarcinoma. With these findings, diagnose prostate cancer. Here's another clinical pearl. If your patient's life expectancy is greater than 10 years, consider ordering a biopsy if PSA levels are elevated, or if you detect a palpable prostate abnormality. Now, once you diagnose prostate cancer, obtain oncology and urology consultations to determine a treatment plan, which may include surveillance, radiation therapy, or prostatectomy. Alright, as a quick recap, BPH is typically identified through clinical findings, PSA levels, and imaging. Patients with mild, moderate, and severe BPH should begin behavioral and lifestyle changes for symptom reduction, while those with moderate and severe BPH also benefit from pharmacologic therapy. First-line medications include alpha blockers and PDE5 inhibitors, while second-line options include 5-alpha reductase inhibitors, anticholinergics, or combination therapy. Patients with severe BPH may also require surgical intervention. On the other hand, if signs and symptoms suggest prostate cancer, obtain PSA levels, MP-MRI, and a prostate biopsy. Once you diagnose prostate cancer, obtain oncology and urology consultations for surveillance, radiation therapy, or prostatectomy as indicated.